Hello everyone, in this particular video we would be going over Hyperemesis gravidarum. So it is a severe form of nausea and vomiting during pregnancy that adversely affects maternal health, leading to weight loss, dehydration and electrolyte imbalance. So these things is very simple, related to the many other diseases wherein we see vomiting. So weight loss is seen because of lack of nutrition, dehydration because you are losing water, electrolytes because you are vomiting, and once again losing a lot of electrolytes. So it can significantly impair day-to-day activities and may require additional intervention, that medical intervention. So what are the investigations that you do? So first, so a thorough evaluation is necessary to confirm the diagnosis of Hyperemesis gravidarum and to rule out other causes of severe vomiting during pregnancy. So what are the tests that we do? First one is urine analysis, second one is biochemical and circulatory changes, third one thyroid function test, next one is ophthalmic examination, next one ECG, USG, and finally we look at the differential diagnosis. So first, what are the investigations? So first, urine analysis. So a small quantity of urine with dark color and high specific gravity. So that is what is seen, small urine quantity with dark color and high specific gravity, because hypovolemia, dehydration is going on. Next one, presence of acetone indicating ketonuria due to starvation. So this one is similar to a starving state, where why you are losing nutrition, and it is hypoglycemic too, leading to ketonuria and leading because of starvation. And occasional proteinuria and bile pigments may be noted in urine. Next, finally, diminished or absent chloride due to persistent vomiting. So HCl, which contains a chloride component, is lost via vomiting. So because of that, decreased or absent chloride due to persistent vomiting. Next, coming to biochemical and circulatory changes. So we have seen electrolyte imbalances, like specifically over there, and circulatory changes. Why? Because considering other features, we are looking at other features too. So LFTs, so this is the first one, elevated liver enzymes in 40% of the patients. Next one, increased bilirubin levels with jaundice in some cases, and finally electrolyte imbalance, so hyponatremia, hypokalemia, so sodium decreased, potassium decreased, chloride decreased, and regular estimation of all of these three is very important. Next, coming to thyroid function test. So clinical, so check for TSH, T3, T4, T3, free T4, TSH, T3 and free T4. About 60% of the women exhibit transient hyperthyroidism. So clinical or subclinical transient hyperthyroidism, increased thyroid activity. Next, coming to ophthalmoscopic examination, look at the eyes, required if the patient severely ill, to check for retinal hemorrhage or detachment indicating serious complications. Next, coming to ECG, to detect hypokalemia and other electrolyte related cardiac anomalies. So this is for specifically secondary to electrolyte imbalances. Next, coming to ultrasonography, confirms pregnancy and exclude molar pregnancy or multiple gestations. So we have pregnancy, right? So we want to confirm that, and we want to exclude other things like molar and multiple gestations, which are also associated with higher HCG, levels and increased risk of Hyperemesis gravidarum. And then we look at what are the other differential diagnoses. So there could be GI, gynecological, surgical and medical causes of persistent vomiting, so which can be learnt in other subjects. So treatment, so what do we do? It's a multidisciplinary approach focusing on rehydration, because we are losing water, correcting metabolic imbalance and controlling vomiting. Hospitalization is number one, indicated for persistent vomiting, weight loss greater than 5% of the body weight, ketonuria and associated comorbidities. Persistent vomiting, weight loss greater than 5%, ketonuria and associated comorbidities. Next, coming to fluid and electrolyte management. Oral feeding is withheld for 24 hours. Because can't eat, right? So oral feeding is withheld. Intravenous fluids are administered using combination of 5% dextrose and ringer solution. 5% dextrose and ringer solution. Total fluid replacement is about 3 liters per day with potassium chloride supplementation as needed. potassium chloride supplementation as needed. Serum electrolytes are regularly monitored and corrected. Serum electrolytes are regularly monitored and corrected. So these are the fluid electrolyte management techniques. Next, coming to antiemetic medications. So we know some already. Here we'll see what exactly is used. The first one is promethazine or prochlorperazone. So this one is not needed. So 25 milligrams of the promethazine and 5 milligrams IM or IV for prochlorperazine. Next one is doxylamine is effective antihistamine for nausea. So we have learned 3 till now: proparazine, promethazine, prochlorperazine, and next coming to doxylamine. Then after that we have vitamin B6, 25 milligrams, and doxylamine combination is also useful. Next one is metoclopramide, which stimulates gastric motility, and ondansetron is used in second line therapy for refractory cases. Next one is corticosteroids. Hydrocortisone 100 milligram IV for severe intractable vomiting or hypotension. So hydrocortisone 100 milligram IV for severe intractable vomiting or hypotension, because it increases the BP. And next coming to prednisolone, which may be used in resistant cases. So we always go with first with hydrocortisone, then to prednisolone. Next coming to nutritional support. So vitamin B1, which is 100 milligrams daily to prevent Wernicke's encephalopathy, because you are not absorbing vitamin B1 and it is consistently being lost. So nutritional, you look at mainly the this one, water soluble, which are lost through the urine. So you try to replenish those. Also vitamin B6, B12 and C are supplemented. Rarely parenteral nutrition may be required in severe cases. Next coming to nursing care, sympathetic yet firm handling, providing social and psychological support. Next coming to monitoring, daily recording of vitals, which is pulse, temperature, BP, intake, output, urine for acetone, proteins and bile. So urine for these 3 things: acetone, protein and bile. Regular ECG monitoring if hypokalemia is present. Next one is hypokalemia or hyper not seen, hypo mostly. So dietary measures, gradual reintroduction of dry carbohydrate foods after symptomatic improvement. So biscuits or bread. Small frequent meals are encouraged. So termination of pregnancy rarely indicated, considered only in intractable cases, unresponsible to the therapy. So again, hospitalization indicated for these things: vomiting, weight loss, excess weight loss, ketonuria and other comorbidities. Fluid and electrolyte management, oral feeding is prohibited. IV fluids are given, which are 5% dextrose ringer solution, and fluid replacement 3 liters per day. Potassium chloride, because potassium and chloride both are deficient, and electrolytes are monitored. Antiemetic, there is promethazine, prochlorperazine, doxylamine, vitamin B6 with doxylamine, metoclopramide, ondansetron. In corticosteroid, first line is hydrocortisone. Then if that doesn't work, prednisolone. It is given for hypotension. Nutritional, for we give water soluble vitamins. Then also extreme cases, parenteral nutrition. Nursing care is given, monitoring of vitals is done, and also ECG. Dietary measures, dry carbohydrate diet, small and frequent meals, and termination in intractable cases. Next, finally coming to the complications, and then we have other things too, but complications are very important. So hyperemesis gravidarum can result in maternal and fetal complications if untreated. So what are the maternal, what are the fetal? So first, maternal, we have divided into different systems. So neurological, because of B1 deficiency there could be Wernicke's encephalopathy. Pontine myelinosis and Korsakoff psychosis could also be seen. So Wernicke's encephalopathy, pontine myelinosis, Korsakoff psychosis. Esophageal, there could be esophageal tears like Mallory-Weiss syndrome. It is Mallory-Weiss syndrome due to severe vomiting. Stress ulcers in the stomach, jaundice from hepatic failure. So esophageal tears, stress ulcers, jaundice. Metabolic, there could be 3 hypos, hypokalemia, hyponatremia, hypochloremia leading to acidosis or alkalosis, hepatic dysfunction with ketosis and elevated uric acid. Cardiovascular hypovolemia leading to hypotension, risk of thromboembolism due to hemoconcentration, because we are causing lots of we are losing water. So, there could be hemoconcentration, increasing the risk of thromboembolization. Next, coming to renal. So, we are losing water, and because of that kidney does not have enough of supply. Because of that oliguria or renal failure in severe cases. And finally, coming to hematological hypoprothrombinemia due to vitamin K deficiency. So, vitamin K is deficient because nutritional deficient, though this is a fat soluble. So, it is a complication. So, hypoprothrombinemia could be seen. And also need to know that this is written at the end. So, fetal complications generally minimal if managed effectively. Okay, low birth weight and preterm in severe untreatable cases. So, that is number 2. Intrauterine growth restriction may occur due to prolonged maternal malnutrition. Next, coming to prevention. So, once again we will look at this. So, maternal complication, fetal complication, neurological we have some for B1. For gastrointestinal we have tears, ulcers and jaundice. For metabolic we have electrolyte imbalances and hepatic dysfunction. And cardiovascular we have hypovolemia and thromboembolic risk. And renal we have oliguria or renal failure. Hematological we have increased hypoprothrombinemia. And fetal complications we have low birth weight, IUGR, preterm. Prevention, early antenatal visits to prompt diagnosis and management, family planning to reduce unplanned pregnancies, and use of antiemetics for milder nausea during early pregnancy, and educating patients on dietary modifications and hydration. Clinical improvement indicators, so subsistence, so vomiting is gone and there is return of hunger. Normalization of blood chemistry and electrolytes, disappearance of acetone from urine and breath, and stabilization of pulse and BP, normal urine output and fetal growth on follow-up. So with this we end the discussion on Hyperemesis gravidarum. We have mostly covered whatever has been asked in Singi. So it includes other things too, like etiology, pathogenesis, other risk factors and all that, but we have mainly looked at the investigations, the management part of it, that is the investigations and the treatment, and also we have added some complications too. So with this we will end the video. Okay, bye bye.